I'm Nat. I'm the events officer, and I'm going to be introducing Graham Cooke, who's going to be speaking today. He is a research professor of infectious diseases at Imperial College London, as well as a member of the WHO COVID-19 Guidelines Development Group. Since March of this year, he has been the principal investigator on 2 different COVID diagnostic studies, which he will be talking about today. So it's my great pleasure to introduce you to Professor Graham Cooke.
Thank you, Rana. Can you hear me okay?
Yes, yeah, I can.
Great. All right, so I'm going to try to share my talk. So let's just, there we go. Can you see that okay?
Have you shared your screen? I can't see it yet. Let me move in. Yeah, perfect.
Great. Lovely. Well, look, thank you very much for the invitation, and thank you for the chance to talk. So you've given me an hour, which is very generous, and I think that even with the best will in the world and my children dropping things in the kitchen, that's going to be a long time. So what I'll do is I'm going to do 3 different pieces of presentation for you, and I hope what we can do is in between take some questions, and each will be about 10 or 15 minutes. And please put questions in the chat, and we can try and pick those up as we go. One of the disadvantages of not being able to see everybody is to know where everyone's coming from and what their background is. So if anything isn't clear, please just ask and I'll try and clarify it for you. So as Rana says, over the last few months, we've been running a number of projects, particularly in relation to diagnostics. And I'm going to touch on 3 things. So first of all, I'll just talk to you a bit about the development of DNA Nudge and the COVID Nudge test. And then for the second part, I'll talk to you a little bit about the REACT program, which is a big national program of home testing, both for detecting virus and for detecting antibodies. So I thought it's probably just helpful to tell you this, and now forgive me if you all know this, but when we're thinking about diagnostic tests, it's quite helpful to be very clear what we're thinking about. So we have to separate the tests that we use to detect virus. And on the left, you've got a cartoon of the SARS-CoV-2 virus. And there are different components of that virus, the spike protein, the membrane protein, the N protein, and so forth. And different tests will detect different parts of that virus. And on the right, we have a cartoon showing the immune response to the virus, antibodies that will detect part of those molecules on the surface of the virus. And so we also have tests that detect that immune response. But we have to be clear when we're talking about this, that these aren't tests for COVID-19. So COVID-19 is a disease, and to diagnose it, you can be supported by tests, both of viral detection and of immune response. But primarily, we have to remember that COVID-19 is a clinical phenomenon. So when we're diagnosing it, we use a bundle of information. We use what the patient's telling us about their initial illness, the time course of their illness, and then some of the characteristic symptoms that many of you will be aware of and some of you have probably had, and then characteristic blood tests and chest x-rays and CT scans and so forth. So this would be a chest x-ray of a typical severe case of what we might call classic COVID, although the irony is not lost that it's only 6 months old. But you can see this white pattern on the lung on the right-hand side is the inflammation that we see with severe COVID. So it's important when we think about diagnostics that we remember that we're using the diagnostics to support us, in this case, in a clinical setting, in supporting a diagnosis based on clinical findings. So the standard of care we have for viral detection is by and large through a nasopharyngeal or throat swab or both, and many of you will have had these done, I'm sure. And usually that swab is taken and put into a viral medium to preserve it. That's then transferred to a lab, which is usually a central lab. And then there are a range of different tests that we use in the lab. Most of them are based on the principle of RT-PCR, reverse transcriptase PCR, which allows us to take the RNA from the virus, make DNA, and detect that at higher levels to find the virus. And usually that process of doing that test and transfer takes about 12 to 24 hours, depending on what systems you're working in. And that test is then sent back to the team who can action it. So it's obviously quite slow, but there are pros and cons to this. So this method we've been using for many viruses for many years, and so it's very well established. People are very comfortable with it. It's done in an approved laboratory, and the results are managed by a clinician who will release them to the team who needs them. And it has good sensitivity. And when we talk about sensitivity, what we mean is the ability to detect virus in people who definitely have it. And it has good specificity, which means the ability not to give a positive test in someone who definitely doesn't have it. And this is underpinned by large companies who have platform technologies and supply chains, which should be fairly robust. So those are all reasons that the current system is what it is. But as I've already alluded to, one of the problems is that it can be quite slow, and particularly where clinicians need to make decisions without those results. So the sort of decisions clinicians are making are, this patient in front of me may or may not have COVID. Where should they go in the hospital? Should they go in an open ward? Should they go into a side room? And ideally, you'd put someone with COVID into a room where the air is vented out, so a negative pressure side room, so you don't infect other people. And there's a limited number of those. So if you have the information about from the diagnostics, you can make that decision more quickly and more sensibly. And at the same time, you can initiate treatment more rapidly. So we do have some treatments. When I wrote this slide, I put remdesivir on. After the Solidarity trial yesterday, I should probably take it off. But dexamethasone will have some benefit, and we would often use that in a patient admitted to hospital. And the other downside of the current system can be that these supply chains from big companies can become vulnerable, and we certainly saw that back in March. So what do we do? Well, one of the things we've done over the last few months is collaborate with a company called DNA Nudge, and this is led by Chris Tunzu, whose picture you see here, who's a long-standing colleague, and I think the closest to a bona fide genius that I've ever worked with, but he's got a long track record of innovation in engineering, and had a company that existed before COVID, which was working in a commercial space doing DNA testing. But as part of that, they developed a system which has been adapted for detection of SARS-CoV-2. And I'll talk to you a little bit more about that work now. So in fact, what I'll try and do, and this might be a bit ambitious for me, but I'm just going to stop sharing for a moment. And if you can see me, this is the cartridge that we use with DNA Nudge. So you can see how it sort of fits in the hand. Probably designed by somebody with a sort of slightly Star Trek or Star Wars bent. And underneath, you can see the design of it. And I'll talk you through a little bit about how that works. So if I go back to sharing the screen again, this is the sort of workflow. So we start here with a standard swab, and then that's inserted into the cartridge through this portal here, and then broken off and left inside. And this cartridge is then sealed and not an infectious risk. It goes into this machine called the nudge box. And then within there, there's a fairly standard reaction. So the chemistry and the detection mechanism in this is similar to the sort of tests we do in the lab. It's how that's done and where it's done that's the innovation. And this box is then linked through Wi-Fi to result systems, and the results can be directed to wherever we want them to be, to the patient, to the clinician, or to the electronic system. And the key thing is that this is fully automated from the point that the swab goes in there, using dry swabs with no transport medium. And this then can be done anywhere. So we have them set up in the hospital next to the A&E and so forth. So just to show you a little bit more detail about this, then this is the cartridge I've just shown you. And within this, there are a number of components. And so underneath what we have are these chambers. And essentially what this carries is a lab reaction that's normally done in series by somebody manually pipetting or a machine doing it. But by rotating this spigot in the middle, the reaction flows in and out of these chambers sequentially, performing all of the reaction within this cartridge. And once that reaction, the elution, the lysis, and the mixing with the reagents is done, the mixture is discharged into this portion, which is where the reaction takes place. And you can see there's a 6x12 array here of wells, each of which has the reaction mixture put into it. And if we zoom in on that, what we can do in each well is put a different reaction. So this particular test takes different parts of the virus, and each of them color-coded as a different target within the virus. And it can have multiple replicates of those particular targets. And these can go across the chip, and they're arranged in a way to ensure there's no error in a sort of systematic error if parts of the chip are working better than the others in terms of detection. And each of these wells is then has an individual reaction, which is then read by the machine. So this is the machine. It's a transparent version, but you can see the cartridge sits in here. This lid slides across and the reaction is then run. Once it's finished, the machine is wiped down, the cartridge can be discharged, and there's no infectious risk to people around. So that does mean that it can be run repeatedly in the same environment by somebody who doesn't need to be trained particularly in how to do it. The box is usually run off mains power supply, but now there's a battery version that's becoming available. And from the commercial company, there's a capsule which can then go into a wristband, which is used to carry information. For our purposes, we don't use that, but that's what the operator uses to start and stop the reaction. And for those familiar with these kind of amplification curves from traditional molecular biology, this is the sort of reading we get from each of these wells. Or one of these chips, I should say, and you can see the different lines for the different wells showing amplification, a rise in the detection of virus at a particular time point. So in many ways, very similar to what goes on in a normal reaction. And we would call it positive if 3 of the 6 different replicates of a particular, of the human RNA amplify. One of the advantages of this test is that it has a human RNA target on it. And one of the problems with most PCR tests is that you can't tell the difference between a test that hasn't been taken very well and a test that's negative. And so you have a human RNA control, and that needs to be positive for the test to be positive. And we're looking at how we might evolve that. But what it means is that if a test is not done well enough, it comes back as an invalid test and it can be repeated quickly, whereas with traditional tests, that can take more time. And you don't necessarily know that it's negative or invalid. So that needs to be positive. And then for the viral targets, you need to have 3 of those replicates positive. If 1 or 2 are positive, we report an indeterminate test. Otherwise, it's reported as negative. And so very early on, we had to move very quickly in March, and we used existing controls to validate the assays in the lab initially, and try and work out the lower limit of detection, how little virus you could detect to get a positive test. And it is very sensitive. It goes down to 5 viral copies per microliter for most of the assays. The assays differ slightly in their sensitivity, and we can talk about that later if that's of interest. And then we needed to do a clinical validation. So we assessed these initially in patients we knew had COVID-19, and we took parallel swabs from this method and the standard method to compare how they worked. And that gave us confidence to do a more formal evaluation, which we went on to do. And this was done really at the height of the first wave in London and the southeast. So being done at a time when the system was under a lot of pressure. And what we did was a very pragmatic diagnostic accuracy study. And if you're interested, the paper was published about a month ago in Lancet Microbe. But we did this evaluation through 3 hospitals in West London and Oxford, and basically just comparing how well the test worked compared to that gold standard I told you about at the start, and using accredited laboratories to do that. And we had 3 groups of patients we could look at. We looked at those who were coming, often healthcare workers, self-referred, because they had symptoms, and so we were able to piggyback on the staff testing programs, looking at patients coming through the front door of emergency, although they started to taper off as lockdown started. So that group's relatively small. And then more latterly, once we started to implement the test, we looked at patients coming through, all patients coming through the door in one of the hospitals to understand how well that worked. And what we were able to show was that there was very good agreement between the laboratory results and the new nudge test. So overall, we think the sensitivity is about 94% compared to if we take the lab test as a gold standard, and gold standard is probably not the right word because even lab PCR is not necessarily a gold standard. But what we didn't see was any positives in the absence of that, so a high specificity. And that gave us confidence to start to scale this up. Out of interest, and this is a slightly technical slide, but it might be of interest to some of you, this is each column here is one of the targets on the chip, which is a different viral target. This is the human control, so obviously this is positive, showing all of these positive results. And what you can see is each row is an individual. Some individuals come positive on all these targets, but some of these assays are clearly not as good as others, and where the grey is, there's a negative. And you can see, in particular, these 2 assays here don't perform as well. So without intending to, by evaluating this multiplex chip in the height of the pandemic, we were able to get a sense of how these different assays were working head to head. And these were the 2 assays developed by PHE, which led to some false negatives early on in the response to COVID. So that's by way of distraction, but just to say that this is a kind of real thing. So from May, we started to use these in some of the hospitals across West London, initially at St Mary's, and this setup I think it's from St Mary's actually. So it shows a room which would have an array of boxes to manage the parallel testing of patients coming through. And we have at Chelsea and Westminster, for example, 2 rooms next to each other, each with about 8 boxes. And this is now being rolled out. And there's about 20,000 tests now being done for patients coming through in the last 3 months. And that meant that we, in parallel to that, we were able to get CE marking, and the company got the MHRA approval for the test. And then that led to a procurement from the Department of Health of 5,000 of these boxes and 5.8 million cartridges, which is now being used to scale this up across the NHS. So hospitals who want to use them can put a request in. I know that at UCLH there's been a request for some through the partners in microbiology. And this is one of a number of tests that are being scaled up to try and address the needs of testing as we look at the second wave emerging in the coming month or two. So very briefly, why has this worked as a collaboration? I think part of it is because we had some existing infrastructure. So we have an NIHR-funded in vitro diagnostics centre at Imperial, which with a range of expertise. And we've got a history of working with companies and with engineering collaborators to develop new tests. And I think I've worked with this particular group for a very long time, very unsuccessfully, I would say. So we've worked on a test here, which we've published on, which is a HIV viral load on a chip, a USB stick, in fact. So you can run this in a USB port. It works very well, but it's never made it to commercial market. And we're currently working with a more advanced a system for point of care sequencing of bacteria in patients with suspected sepsis, all underpinned by a different technology from what's in the nudge test. But the point being that we had existing collaboration which we could draw upon. And what we were able to do was co-locate clinicians, engineers, the company and virologists all at one site and work very closely together very quickly at a time when that was quite difficult. And I think without that, we'd have really struggled to get all this done. So the other thing is to say that we've had a huge number of very engaged collaborators in both the university and the hospital trusts and the government, and that's been hugely helpful. There's been a huge slice of luck. One of the things that turned out was you couldn't get a standard swab into this when we started to try, because it wasn't designed for that purpose, but it does turn out you can get a pediatric swab in. And that turned out to be very helpful when we were running out of swabs in April. And so that's been very useful. So I'm just going to pause at that point. And huge number of people involved in this piece of work. So I'll stop sharing my screen, and then I think there's some questions coming in the Q&A. Maybe we could take those before I go on.
Yes, I'll just read out some of the questions. We actually have quite a few.
Okay, I'll work down. They're anonymous, but if you want, yeah. If we get to your name, we'll put you live, shall we? So the first one is, how many times could one use the machine? Could you buy this box online? Why is it not commercially sold? Okay, so the machine can run as many cartridges as you can run through it, and it would need servicing eventually. But it sits as a base for testing. You can't buy it online because the government procurement has bought the supply chain for the NHS, and that's why it's not sold commercially at this point. Although there are some discussions between the company and some private healthcare providers, which may be helpful. So that's why, unfortunately, there isn't the capacity. And so early on, the government had to make a decision as to whether to put an order in, because you have to get a lead time on the manufacturing line, and that's what happened. How much does it cost compared to a lab test? Well, I'm not going to answer that because the company will do that. What I can tell you is that it's cheaper than most lab tests, certainly than molecular tests, for a cartridge. And if you're going to buy a test commercially, I'd be very wary, because some labs are charging very large amounts of money, over £100, and the cost of the test is much lower than that. And the government has bought this, as I think is in the public domain. They bought it at pretty close to cost. Marta, do you want to ask your question?
I will unmute her. Marta, go ahead.
Okay, can you hear me?
Yeah, hi.
Okay, so I was wondering, because from what I read, this test is using the traditional PCR, right?
Right.
And I've heard about using isothermal amplification methods, like LAMP, for example, which is used by Oxford Nanopore. And then Why did you choose PCR, and what would you say are the, let's say, pros and cons of both of the methods? Yeah,
that's a good question. So the main thing was I think one of the things I've learned from working with Chris over the years is you don't try and mix two new things at the same time. So really what we wanted to do was take off the shelf methods that had been reported. So essentially the reactions that went on were from the CDC, from WHO and elsewhere. And so there was no uncertainty about how they would perform. It's harder to get, so LAMP is something we have worked with, and in fact that HIV work I mentioned, we used LAMP. And so, you know, for those familiar with LAMP, then you'll know that it's actually not very new. It's been around, it's so long that it's off patent now. So LAMP is potentially useful because it could be quicker. It's going to be difficult to do that in multiplex. So it's not necessarily going to be the best solution for this particular platform. But theoretically, LAMP can be faster, and that's its main advantage. Multiplexing LAMP is more complicated. So, but the main thing was that we wanted to take a method that we had confidence in to put on the technology, which we didn't have so much confidence in when we started. So I hope that answers that question. Yeah, how much, I think we've done the cost question. Are there other real-time COVID tests? Yeah, so I mean, there are relatively few that are available. So the main sort of existing commercial platform that we have access to is from Cepheid, who cut their teeth in TB originally. And we have we use their tests in winter, particularly for flu and RSV. They have a platform, unfortunately, and we have that platform, and I imagine UCL do too, but we can't use it very easily because of limited supply of cartridges. So that's been one issue. And there are many other tests being developed, particularly around LAMP, for example, as we've heard, so Optogene and so forth. So there are others, but there aren't very many available at this point and well validated. The next question is, was the heat map from DNA microarray or NGS? No, it looks like it should be, doesn't it? But it's actually just a plot of rows are individuals, columns are tests, and the strength of the intensity depends on how strong the response was. So it's really just a way of illustrating the performance of the test without, but it's not a microarray as such. I understand why it looks like one. Regarding the current issues with track and trace, where is the problem? Okay, so I think that's probably something we can pick up later, or maybe in the Q&A tomorrow. That's a more of a policy question. And is it to do with the rolling out these kits? No. So this is really targeted at hospitals at this point, and people admitted to hospitals. So it's not part of community testing, and that's not something that we've done at this stage, although clearly it could be a component of that. Can this technology be used to detect other viruses? Yes, and that work is underway. And clearly the ambition in the short term is to get flu and RSV onto the chip, and that will allow hopefully better discrimination of patients as we start to see other winter viruses circulating. All right, I think, and the last question, Marta, I'll take is just how long does it take? It takes 60 to 90 minutes. So it depends, but I think at the longest it would be 90 minutes. I think I'm going to pause there because we'll run out of time otherwise. And then I'll just go on to my second talk. And if we have time at the end, we can come back to some questions, if that's all right. Okay, let me stop that. So what I'm going to do just now is to talk to you a little bit about the REACT program. So this is very different, but it still relates to point of care diagnostics. And I think I'm assuming there's a sort of technology bent to this audience. So I hope you might be interested in some of the technology side, but I don't want to suggest that that's the only thing that's important. But what I'll do is talk to you a little bit about that. So Rana, can you see this now? This is, it should say REACT. I'm going to take that as a yes. Okay, so REACT stands for the Real-Time Assessment of Community Transmission. So this was a project that started in April, May of this time that we've been running from Imperial. And I would imagine, hopefully, if not yourselves, but people you know have probably taken part in this. So over 1.4 million people now have taken part in this study. And there are two parts to it. So REACT 1 is what I'll just touch on now, and that's trying to get an assessment of how much virus is in the community at this point. So that goes back to my first slide about detecting virus. And that's what we're trying to do in REACT 1. REACT 2 is about detecting the antibodies, and we'll come back to that in a minute. So I'm just going to focus on REACT 1 for now. And so what we've been doing since May is a monthly survey of the country. This is England, and we're trying to get a sense of each local authority as to how much virus is in there. So there are 315 local authorities, and we select individuals within that to invite for testing at home, and they test themselves. And so we use the NHS database and we invite people to register. And if they're interested to do that, we then send them the kit. They do the test at home and they courier it back to a central lab. And that gives us a very good estimate of how much virus is across the community. And we can also look at trends. And so it gives us a way of measuring R directly and how rapidly the epidemic is growing or shrinking. And it allows us, because of the numbers involved, it allows us to get a much better sense of the geography and of the risk populations who are affected. So on the right-hand side here, you can see the dates of the different rounds that we've done. And I'm just going to touch on some of the data following the most recent round, which finished on the 5th of October, and which you may have seen some reports of in the news. So this is each round, and you can see the proportion of individuals in this last round here who have detectable virus has gone up very substantially. And what this study was able to do, probably before anything else was able to see it, was to see this resurgence really at the beginning of September. And one of the sort of false hopes, I guess, before that was that we were only going to be seeing infection in the younger age groups. And we can see certainly 18 to 24, I don't know if this is the demographic I'm talking to, but there's very clearly a very large rise in prevalence of virus in this age group. But nonetheless, these blue bars from each age group in the most recent round have very substantially risen. So although the change is much greater in younger adults, we see this across age groups. So the idea that this is only being confined to young adults is a mistake, and we know that from our hospital front door, where we're starting to see more admissions. And similarly, we were able to see very early these rises in the northeast and northwest, which are clearly prominent in the national news at the moment, to a lesser extent in Yorkshire and Humber. But again, rises across the country, even in the lower prevalence areas. And so it allows us to build up this map of virus within the community. And you can see this from round 5. In London, relatively low still, but obviously in the northwest, some real areas of hotspot. And we know about Liverpool and the challenges that are being faced in Liverpool at the moment. And you can see across the northwest region, and to some extent the northeast, and to a lesser extent the Midlands, there are still some issues. We know about Luton, which has been in the news more locally. I can't explain what's going on in North Devon, so if anyone has any insight into that, do let me know. And obviously this data is extremely helpful. For those of you who saw the press conference last night, this is how the government uses it to present. And we can talk a little bit about some of the uncertainties around this later, but there are a number of different ways of measuring virus in the community. And the main two studies are this one, REACT-1, and the ONS study, which is obviously very high profile, giving slightly different estimates, and we can talk about that if it's of interest. But what we can see is the trends, which are very clear. And the advantage of having this repeated framework, which is the same in REACT, is that we can be more confident about those trends. And we can see here very much how prevalence is rising in the last round, round 5. This is 1, 2, 3, 4, 5. And again, you can see this, below there. And I won't go through all of these in detail, but this is again showing our ability to break this down into regional trends by month. And at the top here, you see the northeast, where actually, although it's risen, things seem to be potentially flattening off a little bit, whereas in the northwest, if I can find it, where is it? Probably down. It's probably off the bottom here. But in the northwest here, sorry, it is obviously rising as well. So you know, this explains some of the concern about what's going on in Liverpool, Manchester, and elsewhere. And we can get some sense of R. I won't go through this in detail, but looking at the trends through one of these rounds, you can get a sense for what R is doing. And consistently, we're finding R is greater than 1, although not as high as it has been previously. So the epidemic is clearly growing, although it's growing at a relatively slow rate compared to what we saw probably back in March. And when we look at the R rates by region, the only one that is potentially under 1, and the confidence intervals here are very wide, so it probably might well be over 1, is London. And I think that probably explains why at the moment in London it doesn't feel anything like it did in March. But obviously there's the risk that that could change very quickly. So REACT-1 has an estimate that we think about 1 in 170 people are infected at the moment, have evidence of the virus, and it does affect all ages, as I've shown, younger adults particularly, and R is growing. R is above 1, so the epidemic is still growing. But this is giving us really important information about the evolution of the epidemic across the country. And as an aside, it's giving us a lot of experience in doing home testing, which is something that hasn't really been done at this scale before, with people doing their own tests. And we've had relatively few issues we've had to pick up with as a result of that. And this is still important to remember that we're using standard tests. So we're not using nudge, we're using standard RT-PCR in a central laboratory. And actually that is the limiting factor at the moment in scaling up this testing. You know, if we wanted to go to the next level and do 1 million people over 2 weeks, we haven't quite got enough laboratory capacity to do that. So that's hopefully something that might change. I will just pause there again. So that's just to talk a little bit about React 1. So do put your questions in there. So there's a couple of questions. Yeah, so the anonymous question is, what's it been like to work to developing a test in the middle of a pandemic? I guess this relates more to the COVID nudge work, but actually it applies to both React and the COVID nudge work. It's been interesting. So, you know, I do infectious diseases, so that's kind of what I do. But clearly, when you're working with the pressure of what you're seeing in front of you in terms of the disease and the pressure of government and expectation, it's different. But it's not, you know, I think if you can't step up and do that, then you're probably not doing the right job. So it's been an interesting thing to do, I would say, given that I'm being recorded. Can we take part in this study? I'm assuming you mean React 1, if you're invited. So we can't select people to put in, although now 2 of our investigators have both been invited to join their own study randomly. But the whole point of the study is that it's a random selection from a national population. So we select different people for different rounds. And if you're invited and you get a letter, I'd encourage you to sign up or encourage your relatives to sign up. It's really important to us that we get high response rates so that we get a good understanding of where the epidemic is. In France, the government announced that real-time COVID tests will soon be used. They seem to analyze the data in 30 minutes. It's very difficult. So I don't know, Zoe, which tests they're talking about. So probably, I mean, the increasing focus at the moment is moving away from these RT-PCR tests to what's called antigen tests. And so these are a bit like what I'll show you in a moment in terms of lateral flow tests for detecting virus directly. And so, for example, at Italian airports, that's what they're using. And when people start to talk about the scaling up to millions of tests a day, that's really what's going to have to be used. So I would imagine they're not PCR, but I don't know particularly which one that is. Are you in favor of centralization of test processing, or would you have wanted to make use of local labs? You know, again, that's something we might pick up in the Q&A more fully, but there's clearly a good role for central processing because you can put different kinds of machinery in that can handle very high numbers of tests in a day. So I think that is important, and I think it is helpful. The issues around centralization have been more around how that connects to the network of testing at a local level, and the disjoint between national testing and local testing, which is an issue. So yeah, I'm not sure it's one of those things to be for and against. So I think we need both. And certainly we have good labs locally where we are, and many parts of the country do too. So I think what you have to do is have a connected system. And what, you know, the term I'd like to hear used more is like a national grid of testing, so that where you've got capacity in one place, you can transfer that to where it's needed. And I think that may be something that we could do better. What is the mechanism for participant selection? Okay, so yeah, as I mentioned then, what we use is the NHS database, which has most of the country selected. And then within that, we take a sample frame to give us representation in all these local authority areas. And then because we partner with this work with Ipsos Mori, and they do a huge amount of the logistics, I should have given them more credit in that talk. But because they have a good sample frame, we can then make adjustments for what we see according to what we think the population we're testing, how representative that population is. So there's some adjustment there, and that's how we get these estimates. How are testing tools adjusted to increase sensitivity and specificity? I'm not sure that I understand that one. So maybe if you put it in with a name, we can unmute you to ask. In March, reagents were low in supply. Has this been better managed now? Well, yeah, so it was a real big issue in March, and it wasn't just the UK, but we ran out of different reagents regularly for different systems, and so there was no one standard that we could compare to. When we did the nudge evaluation, we couldn't use a single standard, which was not ideal, but we did what we could because it changed every week. There is an issue at the moment. You may have seen, I mean, as I mentioned at the start, you know, one of the advantages that's supposed to be from big multinational companies providing diagnostics is that gives you some security around supply, but Roche at the moment have got a particular challenge And so we have a challenge with Roche Diagnostics across the board, not just for COVID. And they're one of the major platform suppliers. So I think that's something that we have to watch very carefully. And I think it does worry me, actually, that we haven't quite fixed those problems from March, but we'll see. I mean, hopefully we do have more diverse supply chains, and there has been a scale up in manufacture, but we'll see how that plays through. Oh, this is all moving. If using normal tests is the major limiting factor, why isn't nudge used more frequently? I'm not sure I quite understand that, but at the moment, nudge where we are is being used for all patients coming into hospital, which is quite frequently. It's not being used more nationally because actually when you think about the logistics of trying to scale up a new test on a national level, that's quite a big operation. So the company is working really hard to do that, registering interest and scaling up, but it requires a lot of training, it requires infrastructure and support. So it can't happen immediately unless, if you do it too quickly, you get problems and then people lose confidence. So it has to be done carefully. How representative is the REACT sample of different ethnicities? That's a really good question. So we, as obviously ethnicity has become an incredibly important issue, highlighted more by COVID-19, and we take a national representative sampling frame. And if we think that's different from what it should be, we adjust our findings for that. But as I'll show you in a minute, the findings in relation to ethnicity are extremely important, both from REACT 1, but particularly from REACT 2. So we can maybe come back to that if we have time for questions. Okay. I think that's the last one. So what I'll do in that case, I'm learning how to do this a bit better at the moment. End of slideshow, click to exit. Okay, so then I'll just give you my last third, if you like, and then we can use the rest of the time available, if there is any, to take any further questions and so forth. So if you do put your name, if you put your name in the chat, and we can unmute you, and you can ask your question. If you're an anonymous attendee, that's all fine, and we can answer them too. But it might not do justice to what you want to know. Right, okay, so to finish, REACT 2. I'd be very keen to know if any of you later tell me if you've been in this study. So I would hope you have been, but who knows. Good, so again, so just to emphasize that this is a collaborative work. So the main partners here are ourselves at Imperial College, Ipsos Mori, who you'll be familiar with, who are really doing most of the operational side of this. NHR, who fund me, and then Department of Health and Social Care, who fund most of the program. So this is work that we do on behalf of the government. And I've already talked about REACT 1. So I just talked to you about REACT 2. And so REACT 2 is really asking a different question. It's asking a question about who has been infected with SARS-CoV-2. So if you want to ask that question, you need a really large representative sample of the population. And you ideally want to have quite a narrow and defined time window for sampling so that you don't sort of follow a moving target. And what you then need is a reliable measure of previous infection. And broadly speaking, there are these two ways that we could think about doing this. And it requires the detection of antibodies. And as I showed you at the start, not measuring the virus, we're not measuring disease, we're looking at a response to the infection with antibody. And so on the left, we see the sort of kit that hospitals have to do high throughput antibody testing. And laboratory-based testing is well standardized. These tests have very high specificity. In other words, you get very few false positives. They have good capacity, but they do require taking a blood sample and getting it to a laboratory. And they are relatively expensive. And it's actually the transport of blood to the laboratory, which is a huge logistical challenge when you're doing it at scale. Obviously, if you're doing it for a patient in hospital, it's much easier. The alternative, and there are other options, but at the other end of the spectrum is point of care testing. And this is the image of a typical lateral flow test, we would call it, a bit like a pregnancy test, but for a finger prick of blood. And these have variable quality. They have generally slightly lower specificity than the lab-based tests, but they do mean that you can do self-testing. And you can do that with a finger prick, and they're much cheaper, and they don't require transport. So in theory, people can read their own tests, and that allows you to do things at scale and at speed, cost effectively, very differently. However, as you might remember, back in April, there was quite a lot of noise about these tests and how useless they were. So this is just two of many pieces in the media about how these tests were bought, but they don't work. And so we came into this project in this environment where really it was quite a toxic environment for these tests. And we wanted to use them for this population study. So we felt to do that we really had to do quite a lot of preparatory work to give ourselves and other people confidence that really we knew what we were doing. So within REACT-2, we have 5 sub-studies. The main study, the National Seroprevalence Study I'll talk to you about, is called Study 5. But then we have these other 3 studies, which I'll just touch on because I think it's important. I won't talk to you so much about Study 4. But the first thing we needed to do was to, in Study 1, understand how well these tests work. So if you're going to send them out to people in the country, you need to understand how well they work in people who have generally not been in hospital. So a lot of the early evaluation work was done in people in hospital, and that's not really representative. You can expect the test to behave in a different way. If people are sicker, they probably have more antibodies, the test might be more sensitive and so forth. So we used a cohort of mostly NHS staff across Imperial Trust and later on Chelsea Westminster Trust, to people who we knew had definitely had infection, and who would come and actually do the test for us and see how well they work to give us some sort of estimate of sensitivity and specificity. And alongside that, we developed a pipeline in the lab where we would test a whole range of these tests in the lab to see how well they worked in samples and sera from patients who had infection and hadn't got infection, chosen to some extent to be representative of the general population. So we reported these back in July. And of the 11 tests we reported, most have good specificity. In other words, they give you relatively low false positive rates. And the MHRA, the Medicines Health Regulation Authority, have very well specified criteria for these tests. They need to be more than 98% sensitive and specific. So although they had good specificity, they didn't have quite good sensitivity. In other words, they missed cases that weren't always positive in people who definitely had the infection. But nonetheless, we did find 4 tests that achieved sensitivity in the range of 80 to 90%. And through those, this is the particular test we chose, a test called Fortress, which we chose for a variety of reasons, partly because its specificity was good, partly because its sensitivity was good. It wasn't the best, but we had access to a very large number of them. And it's important to remember at this point that we're using these tests for population. We're not using these tests for individual patient management. And so this is done as a research study. People taking part are told very clearly not to use this test because obviously it could be a false positive. What we didn't want is people to change their behavior based on those tests, regardless of what those results were. So on the left here, you can see a negative test. The blood goes in here. Patients drip it in. You put the buffer here and it runs through. And this line is a control line against C. And on the right here, you see one that's been done in anger, if you like. And so you can see the control line, but you also get a line for IgG antibody here. And the more astute of you will notice this shadow here of an iPhone. So we ask participants to take a photo. They report their test themselves into a web portal, but they also take a photo of it and upload it. That allows us to do some validation and verification of the results. But also the less astute of you will even notice that this was a bit of a bloodbath, and this is not untypical for some of the images that we see. And it emphasizes how important it is to work with patients and the public before you do this. And so that's what we did as part of this. And it was really important to get users involved in this. So we started with a public involvement panel, and then we did a small pilot with a small number of volunteers before going to a public panel, testing usability and acceptability. And eventually we did a large, 14,000 members of the public did this for us with 2 of the tests that we thought looked better. This is really one of the largest usability studies that's been done in this area. And all the time with the guidance of a public panel to help us, because we really wanted to understand how to do this best. And we ended up with this kit that we made up with these things. And I won't go through the whole detail, but there were some clear things that we had to do. We learned very quickly that people often messed up their first finger prick. So we made sure we provide 2 finger prick tests. And if we didn't, we had reports of people using kitchen knives and various things that we really wanted to avoid. Some of them used pipettes to transfer blood. It turns out people find that very difficult. So we just got rid of that and told people to drop the blood in and so forth. And that's what we now use and mail out for people as a pack. So to show you where we've got to then, we've now done 3 rounds of this, and we've got over 350,000 people now signed up who've done this. We've got rounds 1 to 3. We're still analysing round 2 and 3, but I'll just talk to you briefly about some of the data from round 1. What we were able to do is, looking at the positive results and what people tell us about their illness, we could recreate the peak of illness back in March and April of this year, which preceded the rise in mortality that we saw in the decline. And what we can see over time is the change in ethnicity. I think one of the questions earlier was about this. And what we can see is that, in particular, those of Black and Asian ethnicity had infection later on in the epidemic. Early on, it was more confined to the white population. and that changed, and we can talk about why that might be. But what we were able to do then is at a local authority area to get some sort of estimate of seroprevalence and national seroprevalence as a whole. And as you can see here, it's very clear that London, as we know, was very much more heavily affected with a seroprevalence in the region of 15% from the first wave. Northwest also quite heavily affected, but many areas like the Southwest much less so. And so there's this clear difference across the country in terms of exposure during that first wave. And how does the government use this data? Well, this is a slide taken from a briefing from Patrick Vallance and Chris Whitty a month or so ago. And looking side by side again, ONS came up with a very similar national seroprevalence to us. The difference with our data is that we have very large numbers, and so we have much tighter confidence intervals around this figure. And more importantly, it allows us to understand much more about the factors that are associated with risk of infection. So, as I've already mentioned, it was much higher in London and lower in the Southwest. It was only very slightly higher in females than males. And similar to what we saw in REACT 1 at the moment, 18 to 24-year-olds had the highest prevalence. And it was very clearly highest in people who work in care homes, even higher in those individuals than those who work in healthcare, although healthcare workers were very much more likely to be infected. Some important things it wasn't associated with are BMI, so body mass index, or comorbidities, and both these things we know are associated with bad outcomes and death, but that's probably because of the difference between what happens after you get infected rather than the risk of infection. And importantly, we also found about 30% of people reported no symptoms, and obviously it's the asymptomatic infections that are really so important in terms of driving the epidemic through the world. And then, as mentioned previously, we saw very clearly very marked differences in ethnic groups between risk of infection. So to show you one data figure, I'll just sort of draw you into this. The reference here is the white population because it's the largest, and each of these bars is for each of the ethnic groups in terms of the risk of infection. And where these bars don't overlap, then that shows that that's a significant difference. And you can see here that the black population, those identifying as black ethnicity, had an infection, a positivity rate in these tests of over 3 times that of the white population, and the Asian population is similarly higher. So there's very clear evidence here that there's a difference in risk of infection between ethnic groups. And we know that mortality has been higher in minority ethnic groups. And so one of the things we can do once we've got a really good estimate of infection rates is to work out what the difference in infection fatality rates are. And what we find here is quite important because although we see the higher numbers of deaths in those from minority ethnic groups, the risk of death if you're infected doesn't seem to actually change very much. So what this is telling us is that those death rates that we see, that the death numbers that we see that are different, reflect differences in infection, and that's where the difference is between ethnic groups. And that's, you can split that by gender and by age group, for example, and you see across all of these very similar numbers. In fact, maybe slightly lower infection fatality in black women compared to Asian and white women over 65, for example. So I think it's very clear from our data in REACT 2 that the epidemic has had an extremely varied impact across the population, particularly by ethnic group, but also by different areas of geography and wealth. And that helps us understand a bit more about what needs to be done to protect the highest risk groups. And again, as an aside to that, what we see is that home testing, both with swabs and with fingerprint testing, is acceptable and safe and reliable at scale and can be done to give us important information. So at the moment, we're finishing the analysis of the second and third waves, and we're starting to try and understand what falling antibody responses mean, both for this analysis and more generally for the risk of infection. And we're starting to link to other groups to try and make the most of this, including, some of you may be interested, we're looking at some machine learning algorithms to help us read these images. We've now got over 300,000 images, and we're actually collaborating with a group at UCL around that to help us. So I'm going to finish there, and this is my acknowledgement slide, which probably misses some people off, but just to emphasize, this is a huge team effort across a number of parts of both the university and the trust, and then also Ipsos Mori and the government. So thank you to everybody there, and thank you for listening. I think we've got about 10 minutes. So if that's all right, I'll pause there, and we can take questions on any of the things I've spoken about if you like. So I've still got a question here: how representative is the REACT sample of different ethnicities? So I think I've addressed that. So I think it's broadly representative. We've got a population sample, and where we have areas that it's not representative, we can correct for that. can we somehow join the study? I don't know if you were here earlier. I think someone asked that. So again, yes, if you're invited, but we can't select you out even as a bonus for attending this session on a Saturday morning. So sorry about that. Which areas of science would you advise us to pursue? That's a very big question. So I don't know enough about who you all are, but if anyone wants to get in touch and is interested in opportunities, then I'm happy to help if that's possible. Maybe on the panel tomorrow we can do that. But if you want to sort of put it in non-anonymously, we can have a chat if that's helpful. Are you planning to increase numbers tested in the next cycles? Well, at the moment, we're still haggling over what next cycles look like. So we probably don't need to increase too much. The seroprevalence doesn't change as rapidly as the prevalence of virus. So we probably won't be doing so many cycles of the antibody testing. I think the debate at the moment is how we focus the PCR testing, given that we know what's happening in the country. And what we'd like to be doing is to use the tool more for intervention and the ability to test large amounts of the population quickly than just describing. Because when you just describe it, you rely on other people to do things. So is the variation in the risk of infection between different, do you think this is due to social economic factors or individuals' own immune systems? Well, that's a very good question, Danny or Dani. It's probably mostly due to social economic factors. We see, for example, that if your risk of infection increases with each person in your household, so there's a kind of stepwise relationship as you add an individual to the household, you have an increased risk of infection. And you can imply from that perhaps that more crowded housing and bigger families and smaller housing are going to be high risk of infection. Plus also that if you're in a key worker patient-facing role that you can't do from home, then you're more likely to be infected. So lots of different factors at play. Is there a genetic difference to that? Well, possibly. And one of the studies we're doing at the moment actually through this is to try and understand that better, working with Genomics England, comparing the genetics of people who've got infected with those who haven't and people who've got infected with mild disease from those with severe disease. So there may be some genetic factors, but I really don't think that's going to be the largest impact on those particular risks. What's your next area of research? Well, hopefully not COVID. I'm kind of ready to go back to my day job, which is mostly around hepatitis C. So that's what I'll be going back to. Could I elaborate on the machine learning aspect of the work you're doing with your colleagues at UCL? A little bit. I mean, I think, as you can imagine, we've got a very big resource of images, and what we'd really like to be able to do is to do a real-time validation of this. So we have a very good bioengineering group in Imperial who are working with this, and we were approached by a group from the iSense consortium from UCL, and they've done some work in this area previously, I think, in relation to HIV testing. So we're hoping that we might be able to get some learning from them, and that's a sort of early stage of collaboration. Can you test samples from 2019 for COVID? Yeah, that's a good question. So I sort of skipped over that a bit, but if you're talking about specificity of the test, then what you really want to have is a set of samples which are definitely negative. And so really to know that something is definitely negative, you need to have got a sample from before the virus emerged. So when we look at specificity, we actually use samples from July 2019 from a particular study that was done working with the police. So there's an archive bank of sera, and we use those to test specificity, and that's quite a commonly used approach from a number of studies. But obviously we can't have viral detection from early 2019. When testing the prevalence in the population through the antibody tests, how long did you assume that antibodies can be detected after infection? Well, that's a very good question. So, we would expect antibodies to be detectable in patients for many months after infection, although the levels of those antibodies may be variable and will certainly fall. And so the question is, for a test that we're using, these lateral flow tests are not like a lab test where it gives you a quantitative number as to what level of antibodies you have. There's a threshold. So if you fall below that threshold, the test will become negative. And so we have seen that, I can tell you, well, I can't tell you too much, but in subsequent rounds, we're trying to account for the sort of competing challenges that we have. So we're having individuals in the population whose antibody levels are falling. and then we've got individuals getting infected. And so we have to try and work out what that means for the overall proportion of people being infected. So I think for all of us, we're learning really about longitudinal effects of antibodies at the moment. Norbert, my colleague from Imperial, has put his name on, so I don't know if you want to unmute Norbert, and we can ask
Yeah,
him.
hello. Good afternoon. So can you hear me?
Yeah, very well.
Yeah, fantastic talk. So thanks very much. I mean, this is now a kind of European problem, isn't it? And I mean, there are lots of travel restriction and so on. So in your testing approach, is there any European approach? I mean, are you kind of liaising with similar initiatives in countries outside UK? Because I guess if you would do that on a European level, you might even get more.
Yeah, I mean, we're not explicitly doing that, and I think there's a number of reasons for that, but I completely accept it would be great if we did. I think two things to say. I suppose we're funded by the UK government, and I think their focus is on understanding what's happening in England, which is where we're working for policy there. And I think there's relatively little evidence at the moment of transmission from other countries, obviously because of travel restrictions. But yes, it is helpful, and obviously other countries are doing own surveys. The closest we've seen in Europe is a group in Spain who published around the same time, published I think back in May, using a very similar approach, although not self-testing, using lateral flow tests. And they looked across Spain at a very big scale, and actually interestingly came up with very similar estimates of seroprevalence. So that probably tells us something, and actually consistently across countries we're seeing quite a lot of consistency in the proportion of people who've been infected, despite the variations in what's done locally. So yeah, I think it would be really helpful. And we've had some approaches from governments outside of the EU for collaboration where we'd be delighted if people wanted to take on the approach that we've used. It would be relatively easy to clone it if you've got funding. There's a question here. So why do we see higher relative rate of infection in the Black community in the UK, but in Africa, the pandemic has not hit to the same extent? Well, I think that that's a complicated question, but I think it goes back to partly what I said before about the importance of socioeconomic factors in the risk of infection in the UK. In Africa, I don't know the data quite so well, but I've seen bits of data from South Africa, Kenya, and Nigeria. And it does seem that actually infection rates there are very high, but of course, there will be social demographic differences in infection rates there that are not the same, that don't divide in the same ways around ethnicity for obvious reasons. The interesting factor in Africa is that there doesn't seem to have been high levels of mortality seen in relation to that. And so I understand that is quite complicated, but it partly probably relates to the demographic pyramid. So as you can, if you remember your demographic pyramids in Africa, you're going to have a much steeper demographic pyramid, and you'll have a smaller proportion of your population who are over the age of 65. And obviously, as we know, there's a very clear relationship between increased mortality as you get older. And in a population like ours, where we have very large numbers of people over the age of 65, that means that we have a very high numbers of deaths related to similar numbers of infections. So that's probably why we're not seeing, well, one of the reasons that we haven't seen quite as much infection. But in Nairobi, if I'm right, and someone might correct me, that I think the seroprevalence estimated is similar to that in London. And there are all sorts of other reasons why transmission might be different. Okay, we are too old and weak. Yeah, okay. So yeah, I think that partly answers the question. I think, have I dried you up? Is that it?
I think that is it for questions. Graham is also going to be on the panel that's tomorrow. So if you do have any other questions, you will have a chance to ask him there as well, and 3 other speakers. We're going to take a break now, and we will be back at 12:30 for 3 other speakers from Behold AI. So thank you so much, Graham. That was a brilliant talk, really interesting. Thank you.
Thanks for the invitation. Thank you, everyone. See you tomorrow.